along the brain stem. So far, between the midbrain and the pons, we have oculomotor and trochlear. Coming out of the pons or going into the pons, we have trigeminal. Between pons and medulla, we had abducens, facial, and vestibulocochlear. And now we're going to go down the lateral aspects of the medulla. And we have glossopharyngeal 9, vagus 10, and spinal accessory, or just accessory. And then we come back up here to the midline near the pyramids for hypoglossal. Now you can see on this side are just rootlets. And here the rootlets have combined together to actually form the cranial nerve. So our models will vary. Some will show 2 clusters of rootlets, or all the rootlets will run together. Okay? So the very first one here is going to be glossopharyngeal. The next one is vagus, and then you may see some weird stuff for accessory. Okay? And then hypoglossal is always back up there by the pyramids. So we're looking at glossopharyngeal. Glossopharyngeal and vagus have all 5 of these modalities. So that's why I wanted to take the break so you guys would be fresh and more coffee or Dr. Pepper or whatever. Peppermint candy. And so glossopharyngeal, you can see here, is the most superior of the ones along the lateral aspect of the medulla. And it is going to be one that is sensory motor or both? Both. It's going to be all 5 modalities. It kind of has to be both. You can see the word tongue in the glosso part, so we know it has something to do with the tongue. And pharyngeal, that's the throat. All right? So we have a clue, at least, with this one about its name. So it shares this first function with cranial nerve 10, the vagus nerve. General, somatic, efferent, the skeletal muscles of the throat for swallowing. All right? So I brought a model of the head up here. And you can't see much of these muscles. It's this thin red line. But it's essentially a muscular tube of 3 muscles that form, if they wrap around like this, and then another one here, and then another one here, grabbing onto the larynx or the hyoid bone or the mandible, maxilla, and they form this muscular tube behind the nose, behind the mouth, behind the larynx. So when you push food towards the back of your throat, it starts a visceral reflex that you either gag and you cough it back up again, or most of the time, you start swallowing. Now that first set of swallowing is voluntary muscles, so I can swallow on purpose. I can start that, but I don't have to actually activate each of the swallowing sequences and squeeze that food down. So once I start that first swallowing, the rest of that is a reflex. Okay? So those throat muscles you see right here, wrapping around like this, are innervated by both glossopharyngeal and vagus nerve. So we're going to put swallowing muscles, or muscles of swallowing, and shared by vagus, or shared with vagus. Then we have autonomic motor. So far, this is the 3rd of our parasympathetic containing cranial nerves. Oculomotor, the smooth muscles of the eye. Lacrimal, the glands, salivary glands, and the lacrimal gland. All right? And now we have general visceral efferent, which is going to be to the other major salivary gland. Rather than going to a smooth muscle, it's going to go to the parotid salivary gland. Do you remember what our word for ear region was at the beginning of the semester? Otic or otic. And so parotid means nearby or next to the ear. So it's this salivary gland right here. This is the one that when it gets infected is mumps. You always see these old pictures of people with handkerchiefs tied around their jaw. Well, I've never known anybody to actually have the mumps. But it's an infection of this salivary gland. This is the major wet, liquid saliva, watery saliva, that contains the digestive enzymes. Now, most of us don't chew food long enough for those enzymes to actually have time to work. All right? But if you take a cracker, or back to that Bisquick, and you chew it long enough, it will start to taste sweet instead of starchy. You chew a potato, a piece of slice of potato, long enough, at least 5 minutes, depending on the size, and not a potato chip, but just a raw potato, okay, or rice, and you chew it and chew it and chew it. That starch, which is long strands of individual glucose molecules and some other types of sugars, will be broken down into sucrose, which if you've had nutrition, are 2 molecules, still too big to be absorbed, but enough to taste. You just have to do it for a while, okay? Most of us just chew it long enough to be able to swallow it. So that's the parotid gland, and that's the major watery saliva. So it's not a smooth muscle visceral efferent, but a gland. All right, then we guess. Maltose is another, that requires sucrase, or because sucrose is glucose and maltose, and that's a single sugar, and it requires enzymes from the small intestine, sucrase, to actually break it down into 2 individual sugars. So, I mean, you could. Glucose and galactose and maltose are the single sugars, but those are actually not released enzymatically until your small intestinal enzymes have effect. But they have to, in other words, sucrase, which breaks down sucrose into glucose and maltose, is not effective except at a pH of 8 to 9, and it's made by the small intestine. It won't work on starch. So you have to have the amylase from your mouth and primarily the amylase in your pancreas to make the sucrose. And then the intestinal enzymes can break it down into glucose and maltose. So it's still sweet because it's sucrose, but it's not small enough to actually be absorbed in your mouth. You can taste it, but you can't absorb it for body activities. All right, so then we have general somatic afferent. And because it's somatic, these are pain, touch, and temperature. Not from the mouth, but from the throat. And because the mouth is trigeminal, if you remember. All right, so from the throat, the back of the soft palate. So if you stick your finger back and wiggle it around the back of your throat and you start gagging, that's glossopharyngeal and also shared with vagus. Okay? Then we have general visceral afferent. And this is the unique one. Notice that part of the glossopharyngeal nerve goes down the neck, and it goes to the carotid arteries. So when we talked about the internal carotid artery going up through the skull, the aorta comes off the heart, and either directly off the aorta or another large branch, 2 common carotid arteries come up the neck. And right about the level of your jaw, the angle of your jaw, they divide and form the external carotid that goes out to your face and the internal carotid that goes up through the carotid canal. So at that point where they divide, there is a swelling known as the carotid sinus. And there are receptors there for pressure. Anybody know what we call a pressure receptor? Well, we're measuring atmospheric pressure, and they're saying the pressure is dropping. Barometer, all right? So there are baroreceptors measuring pressure in the blood vessel, and there are chemoreceptors. What do you think those are measuring? Chemicals, okay? So we have baroreceptors, or blood pressure, and chemoreceptors for oxygen, carbon dioxide, and hydrogen ions. So that's physiology for next semester. So I'm just going to put here that it's sensitive to pressure and chemicals in the blood. Now, to illustrate, what happens if I need more oxygen in my blood? Let's say that I'm hiking at 8,200 feet. What's going to happen to my heart rate? It's going to go faster because it needs to move the smaller amount of oxygen in my body faster so it can get back to the lungs and pick up more oxygen and do that more quickly because there's not as much oxygen in the blood. So the heart rate moves faster, the blood vessels will dilate a little bit to get the blood, more oxygenated blood out to the tissues. So that's a reflex. The glossopharyngeal nerve will be activated by increases or decreases. So it'll send more spikes or fewer action potentials or more action potentials based on these changes. Goes up to the brainstem. And our other cranial nerve 10 is the one that slows down, or we have other nerves that will speed the heart rate up. So this forms a reflex dependent on changes in pressure and content of the blood on whether the heart rate and blood pressure needs to go up or down. Okay? So in the carotid sinus, cranial nerve 9 is the sensory neuron. And the aortic nerve is our next nerve, vagus. So again, these two are working closely together. Okay? And so we have 1, 2, 3, 4. One more. Special. Visceral. Afferent. And this is for taste. What was our other cranial nerve that did taste? Facial. All right? So here is the tongue. Not a human tongue, but anyway. Sweet, salty, sour, done by cranial nerve 7. In the back are special structures with taste receptors for bitter taste, done by the glossopharyngeal nerve. Now, I'm not a coffee drinker. Too bitter for me. I only like my coffee taste in ice cream. Okay, that's my favorite kind of ice cream is coffee ice cream. And I've had, I don't know how many friends that have said, I can make you coffee that will taste like coffee ice cream, and melted coffee ice cream is the only thing that tastes like coffee ice cream, okay? It's either too sweet or too something or another. And when do you get that bitterness? Is it when you first put the coffee in your mouth, or you just dip your tongue in coffee when you taste bitterness? Afterwards. So that's when the coffee is flown back over the base, the posterior part of your tongue. Okay? And its chemicals are bound to these bitter taste receptors, innervated by glossopharyngeal nerve. So sweet, salty, sour is 7. Bitter is 9. Even when we get to vagus, we still have taste receptors, but those are in the mouth more than they are the tongue. Okay? So glossopharyngeal has all of these functions. I'm going to leave those classifications up for vagus. Just change the name. Okay, vagus word meaning wanderer. And it has the longest pathway of any of our cranial nerves. So here's vagus, right here. All three of these nerves go through the jugular foramen, so kind of the posterior portion of the brain. And vagus is most well known, best known for its the major parasympathetic nerve to the viscera. So when I first talked about autonomic nervous system at the beginning of this unit, and I remember I said parasympathetic was rest and digest, and sympathetic was fight or flight. All right, the rest and digest refers to slowing the heart rate down, and digest is increasing the stomach, the small intestine, the large intestinal functions. Okay, it works on bronchial structure, so it's also going to decrease airway. When you're running, you need more air. Sympathetic dilates, parasympathetic decreases.
So rest
all right,
digest is what?
parasympathetic. And we go into this in our next unit, so I'm just briefly touching on this. But you can see that the vagus nerve has a very elaborate pathway. So general visceral efferent, we'll just get that out of the way, is going to be smooth muscle, for the bronchioles. I'll just put airways because there's more smooth muscle than just bronchioles. Trachea, bronchioles. Smooth muscle for digestive tract. So smooth muscle in the stomach, small intestine, 2/3 of the large intestine. It's going to be glands. So also the digestive tract. We secrete enzymes. Pancreas. It's not part of the tract, but it's the digestive organ, liver. And in addition to smooth muscle and glands, it does cardiac muscle. So it decreases heart rate. Individual specific functions you don't have to know right now, okay? So just kind of the general area where it's doing this. And that's what most people recognize the vagus nerve. You get vagal responses and stuff like that, okay? However, before it gets that far down, it innervates those same pharyngeal muscles that we talked about with the glossopharyngeal. So it's going to innervate swallowing muscles. Usually the lower portion, but there's some overlap, including the esophagus. That's part of our digestive tract. And the esophagus, as you'll learn next year, changes from skeletal to smooth. So it's a transition between voluntary and involuntary. So up here it's doing the voluntary, then it transitions to smooth, and we use our autonomic component for that. The major skeletal muscle innervated by vagus, however, are muscles of the voice box. So muscles, skeletal muscles of the larynx. We use these muscles to control the vibration of the vocal cords, so we can talk really high, we can talk really low, or we can talk loud, we can talk really soft. Okay, I'm using the vagus nerve for all of those activities. Speech. Some aspect of speech. Now, there are several different branches of the vagus nerve that we'll cover next semester, but I want to show you one. So here's the voice box, or larynx, and nerves are going into it. But most of the muscles are actually innervated by a nerve that comes all the way down the neck, into your chest, and then goes back up to the voice box. On the right side of your body, it goes around the artery that goes into your arm, upper extremity. On the left side, it goes around the aorta, and then goes back up. Part of its embryonic development. And the reason I mention this is some of you are doing the cerebral vascular accident, a stroke or an aneurysm. And one type of an aneurysm is called a balloon. It's like blowing a bubble. And that gum gets out thinner and thinner and thinner, and then it pops. And so we actually had one of our former lab techs, her mom, had a 10-centimeter aneurysm in the arch of the aorta. That's almost 5 inches. Okay, 2.5 centimeters is an inch, 2.54. So about 8 inches. Almost 5 inches in diameter, 10 centimeters. That's the diameter that the birth canal dilates to when a baby's born, okay, when the mom's ready to start pushing. So we're talking something like that size. John Ritter died of an aortic aneurysm. The kid was the splitting type. But as that starts to dilate, what's it going to do to this branch of the vagus nerve? It's going to stretch it. And so one of the early signs of this dilation is hoarseness in the voice, because those muscles innervated by the branch of the vagus nerve are not getting completely innervated because some of those neurons are getting stretched and are not active. So physicians have to be aware when a symptom is in one part of the body, the problem may not be in that same part. Okay? Not just because of referred pain or senses, but the actual cause may be separate from where the sensations are coming from.